So picking back up where we left off, the etiology of panic disorder, trying to decide which areas really contribute to it. Norepinephrine, GABA are two neurotransmitters that they think play a role in it. But also the brain chemical lactate, as you can see right here, they think also they've seen elevated levels of lactate in those folks that report having panic disorder. So they think that maybe plays or contributes to it. Also, learning, maybe the brain learning that with high concentrations of carbon dioxide, associating that with fear also has something to do with people having panic responses. So, I mean, these things all play into it. Women are also much more likely than men to have panic attacks. So, you can read through in your chapter, in chapter 12, it explains the different theories about the etiology of what develops panic attack or what goes into suffering from it. Specific disorders, you guys, and also social anxiety or social phobia. Listen, if you Google phobia, you'll come up with thousands of different phobias. And basically, a fear becomes a phobia when a situation is so dreaded that an individual goes to almost any length to avoid it. A specific phobia is a psychological disorder in which an individual has an irrational or overwhelming persistent fear of a particular object or situation. These are really common ones down here at the bottom. The specific disorder, irrational, overwhelming, persistent fear of a particular object or situation. And we think, classical conditioning is probably a great way to explain it. For the most part, we think people have been conditioned to fear things. There's been something that was benign paired with something that you really did fear, and the benign thing then takes on a power of its own. So a clown becomes very scary when it's paired with something that was very frightful, fearful at the time. The clown didn't have the power, but after it's been conditioned and those things have been paired up a few times, then the clown takes on a whole new power. Clown phobia. A lot of people have a problem with that. Observational learning too, also watching other people. And a lot of people say they have very similar phobias to the ones that their parents had. And as a result, maybe there's a learned component or observational learning involved with it. Social anxiety, intense fear of being humiliated or embarrassed. And that's probably the key part. The being humiliated in front of other people or just being embarrassed in front of other people is probably the key aspect to that. Sorry, I enlarged it a little bit. See if we can make this go back down. Oop, sorry. Now I'm getting all over the place. Hang on a second. Okay, so genes appear to play a role along with neural circuitry involving the thalamus, amygdala, and the cerebral cortex. Serotonin, that neurotransmitter, we think sometimes there's a lack of serotonin or it's being reabsorbed too quickly. Genetic characteristics or parenting styles might play some aspect of it. Listen, social phobia and anxiety goes beyond just being shy. Being shy and having that personality trait or that aspect to our personality doesn't mean that we have social anxiety. Social anxiety is when you start to avoid situations completely. You're not able to get comfortable in a social setting like a classroom or at a party or other places. Shy people can do that. Shy is just, it's something that is different than what we would call social anxiety. And a person who is extroverted or socially does not have issues can develop social phobia. Different changes in life, maybe relocating to a new place, going off to college for the first time can cause social phobia for some people. So, it's not something that we're always just born with. It can develop later in life. OCD or obsessive compulsive disorder, reoccurrent anxiety provoking thoughts. So having obsessive thoughts about something and then compulsively having to do something to neutralize anxiety, like repetitive ritualistic behaviors, checking, cleaning, counting. Those are some common ones. This is a tough disorder, guys, and I think it's tougher than the other ones are more irrational fears, where with obsessive compulsive disorder, no doubt there's an irrational component to it, but it is much more difficult because you're bombarded with these obsessive thoughts. And then in order to rid yourself of the thoughts, it's as if we need to do a compulsive behavior. And that'll help momentarily, but when we might have obsessions come up later on, 5 minutes later, a couple hours later, whatever that might be. But the compulsions, remember, they're to help actually. And It could be tough. It says as long as a person performs the ritual, she never finds out the terrible outcome doesn't happen. Having a thought that something bad might happen if I don't do something compulsively to neutralize it. Very, very difficult to deal with. Etiology, different ideas, genetic component. We look at the frontal cortex, basal ganglia, also the thalamus. It says one study, a functional MRI used to examine the brain activity of individuals with OCD before and after treatment. Following effective treatment, a number of areas in the frontal cortex showed decreased activation. Interestingly, the amygdala, which is associated with experiences of anxiety, may be smaller in individuals with OCD compared to those that do not have the disorder. Also, low levels of serotonin and dopamine seem to be involved in OCD, and that's where medicines go after trying to increase serotonin flows, increase dopamine flows for folks with OCD. Some of the other ones, I won't go into depth, but hoarding disorder is related to OCD, excoriation or skin picking, trichotillomania, hair pulling, also body dysmorphic disorder are also associated with what we believe to be obsessive compulsive traits or obsessive compulsive. Post-traumatic stress disorder or PTSD develops through exposure to a traumatic event that overwhelms abilities to cope. Flashbacks, having the emotion come back to us in a place where we're safe. Could be sitting in a classroom, be sitting at home or somewhere, and we're bombarded by images of it, or we could have nightmares or night terrors associated with it. Avoiding emotional experiences, numbing myself, also reducing pain through maybe I'm self-medicating to reduce the emotion. Reduced ability to feel emotions, excessive arousal, always on edge, always on the edge of my seat, always scanning the horizon. Difficulties with memory and concentration, and also impulsive behavior. I've had folks tell me that coming back from deployment, maybe a couple tours, struggling to reintegrate into what's more often than not a peaceful society. But I've had guys that said, listen, I went to war a passive guy, and I came back looking for arousal, struggling with fitting in, struggling with having kind of the day in, day out life of a normal, I guess, American citizen. And some friends of mine have said they became aggressive. They went out looking for fights, although they were non-aggressive before. It could have that effect, I guess, not for everybody, but for some people. PTSD symptoms can follow trauma immediately or after months or 7 years, or even years rather. It can be a delayed effect. Most individuals who are exposed to a traumatic event experience some of the symptoms in days and weeks following the exposure. However, not every individual exposed to the same event develops PTSD. No, I mean, it's hard to know who will develop it and who won't. And I don't know if we have a test really designed to predict those that are more likely to develop PTSD. Very difficult to be able to test ahead of time. And even diagnosing, we want to be able to get the right diagnosis to help people, because there are some things that can help. But it's a tricky one. PTSD with OCD, those two are tough anxiety disorders to treat. And I joke and I say, if you want to have a mental disorder, have an anxiety disorder, because we have lots of treatment that's been shown to be effective and proven to be effective. Yeah, for generalized anxiety disorder and panic attack and things like that, yeah, we do. But when it comes to PTSD, when it comes to OCD, those are tough ones. Those sometimes take a while and experimentation with different types of treatments, and they can be very difficult. It says can follow trauma immediately or delayed, combat war-related trauma, sexual abuse and assault, natural disasters such as a Katrina type event, unnatural disasters such as like a 9/11 event. Also, depressive disorders, moving into what we consider to be more mood-related disorders. Depression, y'all, is really just the lack of pleasure, the inability to derive pleasure from things that normally give you pleasure in life. Major depressive episode, it says significant depressive episode having 5 of the 9 symptoms, and those are the main ones listed below. Also for at least 2 weeks or longer, impaired daily functioning. You can read through those blue ones. Depressed mood for most of the day, reduced interest or pleasure in activities that were once enjoyable, significant weight loss or gain, trouble sleeping or sleeping too much, fatigue, loss of energy, feeling worthless or guilty, problems in thinking, concentrating, recurrent thoughts of death, suicide, Not always, but that can be a major part. No history of manic episodes. We have to rule that out too. And it, like, all these disorders, you guys, you got to rule out any substance causing it, or any kind of organic, or so we always have people do blood work. We have them go to their regular doctors just to get a regular checkup to make sure we can rule out any type of physical based issue that could be the byproduct could be depression or anxiety or something like that. Some of the major what causes it, basically etiology, genetic influences, brain structures, neurotransmitter regulation. The main thing that we focus on today is serotonin and norepinephrine. And most of the, like for instance, the SSRI, selective serotonin reuptake inhibitors, like a Lexapro, like a Prozac, they focus on these that serotonin transmitter. Also, the neurotransmitter norepinephrine. Some medications will kind of target that. Substance P, as it says here, is also something relatively new. We're looking at that. Seems to change a person's experience of pain. And certainly you talk to people with major depression, and for some that have been suffering from a major depressive episode, or for off and on episodes that come and go, they'll say the emotional pain is worse than physical pain. It's something that's so intolerable, which I think leads people to suicidal ideation and suicidal plans. I think I've heard a person say it's not so much the fascination with suicide, it's getting rid of the emotional pain, and I'm convinced nothing will. So it's tough to help people, but they can be helped, and we do need to, especially if they're suicidal ideation or they have a plan, then we need to get them to safety. And if that means admitting them inpatient just for a window of getting supervision for 24/7 supervisions where they can't hurt themselves, and we can then come up with a plan, then that needs to be done. Learned helplessness, cognitive explanations for depression. Also, the socioeconomic status. Usually, yeah, people that live, I think, in poverty or struggle with getting needs met and paying bills are more at risk. Women are nearly twice as likely as men to develop depression. So there's some slight differences. Now, hey, a lot of people would say that it's underreported in men, just like anxiety disorders, that women are more likely to report, share with friends, get help, where men are more likely to keep it to themselves or not verbally share it as much, or not get help because of the mentality of pick yourself up by your bootstraps, and seeing it as a weakness possibly. So the numbers might be skewed a little bit due to the fact that men don't report as much as women do. Bipolar disorder, extreme mood swings, including one or more episodes of what we call mania, which is an elevated state, overexcited, unrealistic, optimistic state. Multiple cycles of depression interspersed with mania. So basically, they're at a high level, they're elevated, they're manic, or they're depressed. They're at a very low level. A manic episode is like the flip side of a depressive episode. The person who experiences mania feels on top of the world. She has tremendous energy and might sleep very little. A manic state also features impulsivity. Yeah, they'll make poor choices, sometimes spend a lot of money they don't have. They can be very sexually promiscuous, take risks that they normally would not take. Due to this problem, the mania interferes with their sense of right and wrong, their sense of delaying gratification. It hinders it. Most bipolar individuals experience multiple cycles of depression interspersed with mania, usually separated by 6 months to a year. Unlike depressive episodes, which are more likely to occur in women, bipolar disorder is equally common in men and women. And if you look at, you can see the genetic thing over here, the identical twins. One has it, a 70% chance that the other one does, and it drops significantly for fraternal twins. And then the general population, it's just 1 or 2%. So, but you can see the genetic part of it. I guess if anything, identical twins who share DNA, it shows that there's a strong genetic component when it comes to bipolar disorder. And this also shows, so this is from your book too, shows the different brain scans in a person that has mania and depression. So there's higher levels of norepinephrine and low levels of serotonin. And studies link high levels of the neurotransmitter glutamate to bipolar disorder, which is kind of interesting as well. I'm going to move past suicide, let you guys read about that in your book, as well as Well, I tell you what, we're going to pick back up here with dissociative disorders on the next video because I'm out of time for this one. So we'll be talking about dissociative disorders and personality disorders. The other information about eating disorders, y'all can read in your book about that. Also suicide and suicide prevention, really important to read about. But in terms of kind of keeping it concise with my videos, I'd really like to look at this, dissociative disorders, and also take a look at personality disorders and schizophrenia. Don't leave that out. That'll be in the next video.